My name is Julie Holland, and I am an assistant clinical professor of psychiatry at the NYU School of Medicine in New York City. And I have a private practice in psychopharmacology in New York City. And I've been interested in MDMA since I first heard about it back in 1985. I was a pre-med, pretty sure I was going to be a psychiatrist, and I heard about a drug that psychiatrists were giving to patients, so I got very interested in it, and I started learning everything I could about MDMA, and I ended up writing a paper about it, and 15 years after that I edited a book called Ecstasy, The Complete Guide, a comprehensive look at the risks and benefits of MDMA, and that's a book that I edited with many other people writing contributions and chapters. And it's a not-for-profit book with all proceeds funding clinical MDMA research. One of the most interesting things about MDMA is that it really is unique in psychiatry. There's no other drug like it. Because it's got a methamphetamine base, it is a stimulant where people are awake and alert and they want to talk and they want to connect with people. But because it is this massive serotonin agonist, it basically floods the synapse or floods the brain with serotonin. Because it does that, it's almost like an immediate acting antidepressant or an immediate acting anti-anxiety medicine. So 30, 45 minutes after somebody takes MDMA, most people become very relaxed and happy and content. There's a sense of satiety, like they don't necessarily need anything. Everything that they have is right there. But because it's got this methamphetamine base, they're also awake, alert, completely conscious, cognizant of everything that's going on. They have enhanced memory for the experience, and there's also enhanced memory for early repressed traumas. So it's particularly well suited to psychotherapy, to being a catalyst for psychotherapy, because it's got these qualities. It is both stimulating and relaxing. And in psychiatry, there really is no... they're called anxiolytics. Something that decreases anxiety is an anxiolytic. And in psychiatry, all the anxiolytics are sedating. So there is no immediate acting, non-sedating anxiolytic in psychiatry. But MDMA is an immediate acting, non-sedating anxiolytic. So it's really unique, and it has the potential to be very helpful in the field of psychotherapy. And you really couldn't design a better drug to help you with psychotherapy, and that people are open and relaxed and trusting and willing to explore very painful and often well-guarded and repressed things. But they're completely awake, alert, they remember everything that they've talked about. So it's very well suited as a catalyst to psychotherapy because of that. One of the things I wrote about in Weekends at Bellevue is that there was this one guy who used to come into the Psych ER every once in a while, and he was this really big, muscle-bound, kind of meaty, tattooed thug. And he was an alcoholic, and he also used to, he really seemed to like PCP, and he would often come in intoxicated with PCP. And when somebody's high on PCP, they're very off-putting. He would be so threatening and screaming and spitting and paranoid, and we would have to medicate him with these heroic doses of sedatives and restrain him. And but this one time, this guy came in, and he was like a completely different guy. He was smiling and he was joking with me, and I was like, "What have you gotten yourself into?" And he said, "I'm high, doc. I got some ecstasy." And I was like, "Good. You and I need to talk. Let's go sit down." And it was the first time that I'd ever been able to have any sort of therapeutic connection with him at all. I mean, it was always just like a big scary guy, give him whatever it takes to put him down because I don't want him to hurt anybody. And this was a time when he really was talking. And a lot of these guys, people who tend to like PCP often have antisocial personality disorder, and this patient definitely had antisocial personality disorder. And a lot of people with this disorder have had horrendous chaotic childhoods and have been the victims of physical abuse and sexual abuse. And so I had a pretty good idea, if we were going to talk, we should really just, go for where the money is. And I asked him point blank about his childhood and whether he was physically abused or sexually abused. And he really opened up and told me these horrible stories. And I got him to see that the way that he was acting out in the community was just sort of propagating all the, creating abuse for other people and getting himself abused. And he was just sort of, keeping the cycle of abuse going by the way he was acting. And I really think that I got him to see that he had to, to stop it and start over and pull himself out of this cycle. And he did. That was something that I wrote about in Weekends at Bellevue that I really enjoyed writing about. I mean, that was like a very special night to me. MDMA is not a hallucinogen, and it doesn't create hallucinations. It doesn't give you visual hallucinations. It doesn't give you auditory hallucinations. So it's definitely not a hallucinogen. And it does induce an altered state that is not the normal waking consciousness. But I don't necessarily think that it is a false state to be in. I mean, somebody, it's somewhat of a subtle shift in consciousness. I mean, to some degree, it's almost like if you had a glass of wine or 2 glasses of wine and you felt sort of relaxed and you started talking and opening up. It's not really that different when someone takes MDMA. And to me, it's, the person that is sort of revealed in this process is the more genuine person. That, some of the pretenses and the masks really are taken off. And what you're left with is more real and more genuine as opposed to less. One other unique thing about MDMA is that it induces, in most people, this sort of a heart opening and a sense of connectedness and empathy with other people. That may be because it enhances oxytocin release in the brain. And oxytocin is felt to be a hormone that is involved with bonding and what's called affiliative behaviors. You're on my team. I'm affiliated with you. So when you're talking about psychotherapy, one of the most important, what's the right word here? When you talk about psychotherapy, one of the most important predictors for a successful outcome of psychotherapy is something called a therapeutic alliance, which is believing that the therapist is on your side and the therapist is there to help you and that the therapist is an ally and that you are going to align yourself with them. And with this, between the massive serotonin release and the massive sort of oxytocin flooding, this therapeutic alliance is really enhanced. And you feel good about yourself, you feel good about the people around you. So if the therapist is around you, you basically, the self-love sort of spills outward and you love the therapist. And there's also a sense of trust. I mean, oxytocin is felt to have something to do with trusting people. And so, and there have been really interesting clinical studies where they've given intranasal oxytocin to people and shown that they trust other people more when this happens. So in a psychotherapy situation, if you can trust that the therapist is there to help you, that will go a long way toward making having a more sort of positive outcome of the psychotherapy. One of the things that I think, but I'm not sure, and I don't know that other people think this too, is this idea of self-confidence or self-esteem, or take that one step further and it's sort of grandiosity, delusional grandiosity. Sometimes you see this in people who are bipolar, who have manic episodes, where as they get more manic, they have sort of a more expansive sense of themselves and what they can accomplish. And you'll sometimes see this in people who've taken psychedelics, that, to the point where somebody may feel like God or like they've created the universe. So very grandiose and powerful, an exalted sense of self. And my assumption is that this is a sort of serotonin-related phenomenon, that when you're depressed and your serotonin levels are low and you sort of have diminished self-worth and you don't feel very good about yourself, as opposed to somebody who's in a manic state where they feel great about themselves and like they are all-powerful and all-knowing, and that may be a higher serotonergic state. So when you give someone MDMA and their serotonin levels in their brain increase, they tend to just feel better about themselves and more self-confident, more able to make changes in their lives, more sure of the sort of the path they're going on or the vector where they're going. In terms of what part of the self, or people having different selves. I mean, I think that gets very complicated. I mean, I think that a lot of people have sort of different facets of themselves that they show other people. And, one of the goals of psychotherapy is that you really integrate all the facets into one cohesive unit called the self. I think most people aren't that integrated or that cohesive. I think that a lot of people show different sides to different people, and they act different ways with different people. If you look at Peter Gasser's work from I think it's the early 80s, there were over 100 patients and over 800 MDMA-assisted psychotherapy sessions performed with no adverse effects, no untoward outcomes, no sort of negative side effects reported, basically. So, I mean, one thing that you see is that when you're taking sort of a known quantity of a known substance in a medical setting or a therapeutic setting, it's very safe. I think in a recreational setting where you're taking multiple doses and you don't necessarily know what you're taking, you're going to have a lot more risks, a lot less medical safety. In terms of its effectiveness, it's really, there were never double-blind studies performed with MDMA until very recently, and that data is actually going to be presented this weekend at the conference. So we don't know yet. I hear that the data is very promising, but the studies, the work done with MDMA before it was illegal, they weren't double-blind, placebo-controlled studies, which is sort of the gold standard for deciding whether something works or not. But when I was working on the book, I spoke with many people who performed the therapy, and they were really impressed with how effective it was and how good it was for things like simple phobias and post-traumatic stress disorder, and also working with couples and with groups. And Shulgin talks a lot about how much it really was good to work with couples and how they would sort of stop what she called the accounting or the housekeeping. You did this and so I did that, and it's all, tit for tat, and they could just push all that aside and really get down to the meat of what was going on in the heart of what their issues were as a couple. So I think that it has the potential to be very useful in couples therapy as well. MDMA does seem to exhibit something called cumulative tolerance, which means the more you take it, the less you get out of it. I mean, there really are diminishing returns. And I actually think that that's one of the better things about this drug, and that if you're smart, you get the message, you hang up the phone. You don't keep going back over and over and seeing whether you can get the same message again. The first and maybe the second time that you take MDMA, you're going to have more potent, powerful experiences than you are the third and fourth time, and certainly the 10th and 20th time. But this is not, Prozac. It's not something you have to take every day. I mean, if you're taking it in a psychotherapeutic framework, if you're doing MDMA-assisted psychotherapy, you really probably only need to have 1 or 2 sessions to really have enough to work with. It's almost like, taking a big bite and you can chew it later. And that if you have a therapist, you will uncover enough things in one session that you could spend a year digesting them and processing them and sort of reminding yourself about, these are my issues and I have to keep working on these things. So it's not something that you really have to do repeatedly. And the way the FDA approved studies are set up, there's 2 sessions, maybe 3, and that's really enough. You don't need to keep taking it. The way I sort of envision MDMA being utilized is simply that psychiatrists or psychotherapists could be giving it to their patients to have enhanced therapeutic experiences with them. A lot of people, most people I would say, carry around a lot of baggage and past traumas and places where they were hurt and they've sort of shut down. And so in general, people aren't as open and trusting and loving and happy and relaxed as they could be. So I suppose in a world where more people were undergoing MDMA-assisted psychotherapy, you would have more people who were happy and relaxed and more trusting of other people and more caring and more empathic and empathetic. The people talk about world leaders being able to take MDMA so that there could be peace on their borders or within their countries or things like that. I mean, I don't usually talk like that. I don't usually think about those things. I'm a psychiatrist. I tend to think about patients and which patients could really benefit from it. I don't necessarily, think about like turning the world on to it. But I do think there are particular patient populations that would absolutely benefit from MDMA-assisted psychotherapy. People with post-traumatic stress disorder do very well with MDMA, and there are clinical studies now to back up what I'm saying. And it's very possible that people with autistic spectrum disorders like Asperger's might do well with an MDMA experience. I'm particularly interested in schizophrenia, and that is a patient population that I really feel a particular allegiance to, and those are people that I really want to help, and they're really suffering. And I have made the case for many years that MDMA may be helpful in the short-term reduction of symptoms of schizophrenia, which may just offer the patient a little bit of respite and a chance to connect with family members a little bit more deeply. One thing that prohibition has a very negative effect on is medical safety. Because this drug is illegal, when somebody buys ecstasy, they may be getting MDMA, or they could be getting any number of chemicals that are not bad for you or horribly bad for you. And that's really, because of prohibition, the issue of drug substitution and counterfeit pills and things like that is very much an issue. In terms of research, it's really hard to do Schedule I research. And a lot of universities will say, it's very interesting, but not in my backyard. I don't want to have that here. I don't want to have that kind of baggage here. And we've seen this happen over and over again in different, in medical school settings and university settings, where they don't want to do MDMA research because it's too controversial and it's an illegal drug, and they don't want to sort of buck the trend. The government, if it's in Schedule I, the government's saying there's no medical use, so why would we want to do research to prove that there is a medical use? It really makes it very difficult. And, there were trials, basically, that went on where a DEA administrative law judge heard hours and hours of testimony and made the decision that Schedule III made the most sense. And Schedule III would still be it would be a prescription medicine, and there would be a lot of restrictions on it, but it would be much, much easier to do clinical research with it. But the DEA did not take its own administrative law judge's recommendation, and they went ahead and put MDMA in Schedule I. And, what's interesting is MDMA has been in Schedule I for 25 years now, and it's, just as easy to get as it's ever been, if not more. I mean, it's become a very popular drug of abuse. Millions of people around the world are taking this drug recreationally, but it's nearly impossible to do medical research with it. So it's very frustrating because, it's an interesting compound, and we need to know more about it. We need to understand the risks and benefits more, and the only way you're really going to understand it is to do clinical research. And with it in Schedule I, it's very difficult to accomplish anything like that.